How you doing? All right. I am Mike Udell. I'm an associate professor here at the School of Public Health, and welcome you to another installment in our outstanding Grand Round series. Dr. Newshafer will introduce our wonderful speaker, Dr. Robbins, in a moment, but I just want to remind you that we have 3 remaining Grand Rounds for the rest of the academic year. They are all outstanding talks. Sandra Galea from Columbia will be here on February 9th. Bobby Ryder, President and CEO of the National Center for Farm Worker Health, will be here on March 1st. And on April 12th, Susan Reverby from Wellesley College will be here to join us. So without further ado, let me bring up Dr. Newshafer.
Good afternoon, everybody. So can anybody define secondary prevention for me? No points. What's secondary prevention?
Detecting a disease, like when it's in the beginning stages, preclinical stages, so you can reverse or stop.
So you can intervene. And so over here, so you detect early and intervene. And this is something that we learn and we teach in School of Public Health, right? Primary, secondary, and then tertiary prevention. So today's Grand Round speaker is sort of working at does work at the cutting edge of secondary prevention for autism spectrum disorders. Our speaker is Dr. Diana Robbins. She's, as you can see, she's an associate professor of psychology and neuroscience at Georgia State University. She characterizes herself as a developmental neuropsychologist. Would not say that she's a public health person, doesn't have an MPH, but really in the field of autism, the work that Dr. Robbins has done has been some of the leading work in secondary prevention for autism spectrum disorders. And I would say that probably in terms of public health impact in autism, the work that's gone on around early detection, early identification, so we can get kids into interventions earlier, has probably had the broadest population health impact on outcomes for the population of individuals in autism in the United States. So this is very important stuff that you're going to hear about today, and you're hearing about it from a very important person. So Dr. Robbins trained she got her undergraduate degree at Oberlin College, and she did her master's and her PhD at University of Connecticut, working with Debbie Fine, who's a senior and very well-respected leader in autism research. She started her work on early detection and autism screening as a new graduate student. So the path that she took began, when she was at the same point in her career as many of you in this auditorium are. As I mentioned, right now she's an associate professor at Georgia State. She's has federal funding for a number of different projects in autism research, published in most of the leading journals in our field, and we are delighted to have her here today. So, Diana.
Well, thank you for that warm introduction. I'm very happy to be here. I've been talking to people from many different disciplines about the work that I'm doing, and I think one of the most exciting parts is that the things that I do in my research has relevance for pediatricians and people in public health and families and neuroscientists and many other disciplines. And so that's one of the best parts, is I get to meet people who come to autism and screening from all different angles. So I'm going to start by doing a quick acknowledgement. There's no way I could name everybody, but my team at Georgia State is fantastic, and these are some of the students who are currently involved, and I try to list as many as I can of the former students and our funding sources, including NIH and Autism Speaks, and of course my collaborators at the University of Connecticut. They are fantastic, and Debbie was a terrific mentor, and she's a wonderful co-investigator now and collaborator, so I acknowledge all of those folks as well. And a quick disclosure, I'm talking about a tool that I developed. This was my baby in graduate school, and so it's not possible to be objective, but I will tell you that I think I'm also my biggest critic, because I'm always looking to see what we can do better and ways that we can dig into our data in different ways. So I tried to give you as big a picture, as clear a picture of the data as I can. And we now actually have a small business for people who are trying to create commercial screening tools. But the work I'm talking about today is all based on the paper and pencil MChat, which is available for free. So just a few objectives of what we'll try and go through today. I wanted to give you a little bit of a picture of what autism features look like in very young children. You know, many people are familiar with autism now. It's gotten a lot of media coverage in the last decade or so. Many people know somebody on the autism spectrum, but what it looks like in toddlers, not everybody is as familiar with. And then I'll turn to several screening issues. I mean, we could talk for like 10 hours about all the screening issues, so I just have to touch on them briefly. But then what I'll do is I'll try to talk about the data we have on the MChat as a tool to screen for autism, as a way of showing you kind of how we've addressed some of these issues. So autism spectrum disorders are defined by 3 domains of symptoms. And the one that I really think of as the primary domain is the difficulty with social relatedness. And what we look for in very young children is children who are not trying to draw adults' attention to what they're doing. Most toddlers who are typically developing are all about getting you to be excited about what they like and what they're doing. But our toddlers on the autism spectrum, they're not pointing things out. They're not trying to get you to look at or comment on objects alongside them. They're not paying as much attention to the parent's face or voice. They're not showing as much interest in other children. So again, typical toddlers, they're all about pointing out another kid and saying, baby, baby, because they're fascinated with other children. And our children on the autism spectrum are more likely to be focused on their own activity and less concerned about who's nearby and what they're doing. They're also not looking their parents in the eye as often, which is an important part of connecting to other people, or bringing things over to their parents. So again, a picture that they drew on a piece of paper or a pretty leaf that they picked up on the ground, they're going to enjoy it, but they won't draw your attention to it by holding it up, showing it to you, handing it over so that you can comment on it. Statement where they said, okay, this is what general pediatricians should be doing. They should be doing surveillance, so informal observations, keeping notes, taking careful histories at well-child visits. And in addition, they should do 2 things. They should do broad developmental screening, looking at a wide range of possible developmental issues at 3 time points. And regardless of the outcome of surveillance or the broad screening, every single child should be screened for autism specifically at 18 months. Then there was a little comment published about that paper, and then the recap came out saying, okay, screen twice for autism, once at 18 months and once at 24 months to reduce the chances of missing any children who have an autism spectrum disorder. So I thought, this is amazing. Everyone's going to start screening kids, and we had been working really hard getting pediatricians to screen. But it turns out that pediatricians can consider these guidelines and choose whether they'll implement them or not. There's so many of them, and they don't have enough time to do everything, and it's not always a given that the AAP says do it and then all the doctors are doing it. So there's still work to be done, but I have seen a shift from when we started doing this research in terms of people's interest and willingness to do the screening in their practice. But we're still far short of having universal screening. Even just the broad developmental screening, we're just under 50% of doctors in a recent survey endorsed offering that screening to their patients, and the number is likely much lower for autism screening. So what are some of the issues? Why is it hard to do? Well, the level of screening is a critical issue. So I think of a level 1 screening as more universal. You don't need any risk factors, you just apply the screening to everybody and see who has some risk. Level 2 screening is a narrower base because you're looking at children who already have some risk for the disorder. So level 1 screening needs to be really cost effective. It needs to be quick and cheap, or you can't possibly give it to everybody. Level 2 screening can be more intense. You can spend 20 or 30 minutes observing a child for a level 2 screen, but you can't do that for every single child. The age of screening. So the AAP has their statement now, 18 months, 24 months, but that's not empirically driven. There wasn't research showing what the added value is of the repeat screening against the cost of screening every single child that second time. And some new papers have come out suggesting that 18 months is good, but we can screen kids at 12 months. I think the jury's still out on whether 12-month screening is really effective, but we certainly need to do better research on it and evaluate the pros and cons of going younger. How do you get your screening data? So parents, in some ways, are the experts on their children. They know what they're like in all different settings, all different times of day, all different moods. But parents are not experts on general development. So when you ask them if they're doing something that's appropriate for their child's age, they may not know what's appropriate. And so the physician's the expert on development, but they have such a small observation of the child in an unusual setting. Kids don't like going to the pediatrician. They're not their happiest when they're there, so they may not be as social as they are in other settings. So there's really a give and take here, and I think the initial, for level 1 screening, the data is really falling out in support of parent report for the initial screen. And then when you get to level 2, where you can spend more time with the child because it's a much smaller pool, then having a professional do some observation can be crucial. And then finally, there's this question about broad developmental screening versus having separate screening tools for specific disorders. And I think it would be fantastic if broad developmental screeners were able to identify all the children at risk for autism, because then we could make the autism screening level 2, where we could spend a little more time on it, but only give it to the children who show some risk. But there's not yet adequate data to support using one of these commonly used broad developmental tools like the Ages and Stages questionnaire or the PEDS, where the parents answer 10 questions very broadly about development, at whether that will flag all of the children who need the more intense autism screening. So these are some of the key issues. I wanted to just pause for a minute and remind you again about surveillance versus screening, because I think that that's really important. The AAP in that policy statement talked about surveillance as being flexible, longitudinal, continuous, and they really highlight how the clinician's expertise is critical for good surveillance, and that they use several different approaches to gathering their data. They talk to parents, they gather history, they look at the child, and they compile all of this in a clinical way to make a judgment about whether there's risk or not. In contrast, screening is very empirical. It doesn't require expertise because it's standardized. So you use a tool that has been developed so that you administer it a certain way, you score it according to the instructions, and then your score tells you if there's risk or not risk. Or it could be multiple levels, like low risk, medium risk, high risk. But you have a score, and there's an interpretation for that score. And so you can see how they're very, very different, but they can actually complement each other. The tricky thing is that they hedge a little bit in their policy statement and say, well, there isn't just one screening tool out there that is going to work for everybody, so you have to figure it out. But you can see how the two in concert might be the most effective ways of identifying children at risk for autism. But the data does show that physicians who rely on surveillance will not identify most toddlers with autism spectrum disorders. When they're older, I think that their identification is much stronger. But in terms of kids who are very, very young, the surveillance is not adequate. So one more key issue is the idea of efficacy versus effectiveness. And the truth is there's probably about a dozen or so different definitions for these terms. So bear with me if mine aren't exactly mapping onto some of the other ways that you've thought about it. But I like to think about efficacy research as mostly, it's what I've done so far with the screening data that I'll talk to you about. You take an ideal setting where you can control as much as you can set it all up just the way you want it, you have experts available to help collect your data, and so we think about the research support that we offer all of our pediatric practices who are in our screening studies. We score it for them. We call the parents and ask the follow-up questions. We offer them the diagnostic evaluation when the children show autism risk. We do it free. In fact, we pay them to come see us in our clinic. And if they can't come to our clinic, we go to their house. Not very many practitioners are able to offer those kinds of supports because you would never make any money. So effectiveness research is a critical next step, right? So when it works in the ideal lab bubble that you've created, what happens when you go and put it out in the real world? Can it sustain? Do the scores mean the same thing? And so this transition from your research lab to the field, which is the real world, is critical. And sometimes things that look beautiful in the lab fall flat when they go out in the real world. So we have to really measure this transition carefully. And so with autism screening, the pediatricians have to figure out how to build screening into their workflow. So if they have 12 minutes with each patient, they have to figure out when the parent's going to fill out the questionnaire, who's going to score it, when they'll score it, who's going to look at it and see if the score is above the cutoff or below the cutoff. And it's really, really important when you're looking at the real world side to figure out which children are at risk for slipping through the cracks in this system. And so this is where I really see my work going in the near future. But back to the efficacy data, because this is going to lead right into the work that we've done so far that I want to summarize for you. There are two more key concepts that I think you have to have a sense of. When you want to know if a tool is valid, what you're really asking is it measuring what I think it's measuring? And that's very different from the question of whether your tool is reliable. Because that question is, will I get the same result time after time after time, or with different kinds of reporters or different kinds of settings? So consistency tells you if a tool is reliable. Whether it's really measuring the idea, the concept you're trying to measure, tells you about validity. And one of the ways that we look at validity specifically is through several of these psychometric properties. Have you guys learned terms like sensitivity and specificity? Okay, excellent. So this is a quick review. And you should tell me afterwards if this color coding worked, because I was trying to condense it into fewer slides. So sensitivity is in red. And so you can imagine that every time you want to know how a tool is working, you can make a 2x2 matrix here, where this is the true diagnosis, and this is your screening result. So a screen positive means the child is showing signs of autism. If they really have it, they're a true positive. If they screen at risk for autism but don't have it, they're a false positive, okay? So that's the gist of how this table works. So sensitivity is whether you can detect the autism when it's really there. And you can turn it into a formula where you take the true positives over all ASD. You sum this whole row. And in contrast, in green, we have specificity, which is detecting the non-autism when it's not there. And so the formula here is your bottom row, where you look at your true negatives. So they don't look like autism on the screener, and they don't really have autism when you see them. Now, the caveat is, if you really want to know all of these true and false negatives, you have to see every single child. So in large-scale screening studies, we can't do that. So what we do is we screen them, and then we set up as many ways that we can of finding the false negatives or the missed cases, and then we presume that the majority of the others are true negatives. And it's a weakness in screening research, but it's one that, unless you have billions of dollars and staff and resources, that we have to live with. So the other two properties, just to point out really quickly, are predictive value, and that really talks to you about the confidence you have in your screen result. It's the likelihood that your result is accurate. And this time in this 2x2, we're looking at the columns. So it's still the true positives on the top, but now you're summing it with the false positives. And the negative, again, is the other column, where you're looking at your true negatives compared to all your screen negative cases. So the AAP in those papers, they only focus on sensitivity and specificity. And if we had left it at that, we would be in good shape, because our sensitivity and specificity estimates are pretty strong. But I was really interested in the confidence in the screen result. And so I started talking in some papers several years ago about the positive predictive value, which is actually the MCHAT's weakest psychometric property. But I think that we have to understand it, because if pediatricians will override a positive screen because they're not confident that it means real risk for autism, then the screening will not actually achieve its goal of getting those screen positive children to see a specialist who can look at them in more detail. So this tool that I keep talking about is the modified checklist for autism in toddlers. And what we did is we adapted it from a British tool, the chat, and we dropped their observation section because nobody here in the US could go into kids' homes and observe their behaviors. And we expanded the parent report section to cover a broader range of behaviors that we thought would show risk for autism. We also broadened it from looking just for children at risk for autistic disorder to the whole autism spectrum. And then once the chat follow-up data came out showing that the high-risk scores only identified 20% of the children with autistic disorder. Our next goal became to increase the sensitivity dramatically from those British studies. So I know you can't read it, but what you can do is go to the website. It was on my first slide. It's mchatscreen.com, and you can download it and read it in more detail. But the reason I put it up here is to show you that it's a very simple one-page screener. Each question has a yes and a no. It's at about a 5th grade reading level, so most parents are able to get through it in just a couple of minutes. We also have a structured follow-up interview that we use to clarify responses, get some examples of what the parents were thinking about when they circled the answer that they circled. And what we do is we follow up on each item that shows risk for autism. If they answered in a way that doesn't suggest risk, we don't ask about those items. So the interview usually takes about 5 to 10 minutes. So we've published on parts of this sample over the years, starting in 2001. But what we're about to complete is the study of our entire low-risk sample. So low risk is also level 1. So all of these children were screened during a pediatric checkup. They were not flagged for autism risk prior to the screening. So we have just under 19,000 children, and just to kind of take you through what the data looks like, the vast majority of them pass the screener or show low risk for autism. So if at this point the surveillance doesn't suggest risk, broad screening doesn't suggest risk, and the MCHAT doesn't suggest risk, they're good. You should still screen them again at 24 months, but they're good. But these kids suggest some risk for autism, and they need that structured follow-up interview. And so in this sample, it's about 9%. And we know autism is not 9% of the population. But in order to find as many children on the spectrum as possible, to maximize sensitivity, we cast a very broad net to find all of those kids, and then we, of course, bring in several other children. That's what the interview is for. It's to reduce that false positive rate. Unfortunately, there are always some families that we can't get on the phone or that don't want to answer our questions. But you can see that of the parents who completed the interview, which was most often on the phone, the vast majority of them no longer showed significant autism risk. Only 272 continued to show risk after we talked to them and got more information. And then we evaluated an additional 42 children. Sometimes we couldn't get them on the phone, but there was a way to get them into the clinic, or we could go see them at the doctor's office. A couple kids, there were 1 or 2 who were about to move out of state, and it was like, get them right now or you're going to lose your chance. And then we also saw some children because the pediatrician had concerns. And so even though the parents did not endorse autism symptoms, we saw the child anyway. And so what we ended up with is, out of this 272 who showed risk, 92 of them had an autism spectrum disorder, and 79 did not. Out of the children that we saw for other reasons, mostly for the pediatrician's concerns, most of them were not on the autism spectrum. So the pediatricians were not necessarily flagging the children who really had an autism spectrum disorder. Now, I will point out that the vast majority of these kids were not typically developing. Most of them had significant language or cognitive delays that needed an intervention. So they were not totally healthy children, but they didn't have an autism spectrum disorder. And for those of you who just want a little more information, these children range from 14 months to 30 months. And the average age of screening was 20 months. So it was just after their 1.5-year checkup. And it's not as diverse a sample as we would like, but we had just over 20%, about 24% were non-Caucasian families. And we're hoping that as we continue to do these studies, we'll have big enough samples to divide children by race and ethnicity more finely. So let's see what these psychometrics look like. The positive predictive value for autism, if you just go by the initial paper and pencil screen, remember 9% of the kids screened positive, and we know most of them don't have autism. Not looking so good. But when you do the follow-up interview, it gets much, much better because, again, we weed out many of those false positive cases. But if you look at the children who had all developmental delays or developmental concerns, so as I just said, most of the kids we saw for evaluation were not typical, it turns out our positive predictive value is 93. So you can be 93% confident if a child screens positive on the MCHAT and the interview that they have some kind of notable developmental issue that needs attention. And so that feels a lot better to us than looking at just autism alone. Sensitivity, specificity, and the negative predictive value are all estimates at this point because we are continuing to try and track down all of these kids when they're older and do additional screening to see if they really are true negatives. Remember, I said we have many things in place so the pediatricians can flag children, but we're also screening them when they're 4 or older with 2 measures, plus asking if anyone has ever voiced any concerns about autism, like the school or the doctor or the parents read something and then they got worried. And we're trying to see all of those children so that we'll have more definitive data. But this takes time. Back when we started this research, people questioned whether you could really diagnose autism at age 2. The doctors were worried about it, professionals were worried about it, and so we have a paper with some of that data that I just showed you, showing that the vast majority of children who start out at 2 with an ASD diagnosis retain it. Now this 15 over here is actually pretty interesting because you could wonder if we just messed up and those 15 kids really didn't have autism to begin with. But if I showed you video, they would look like the kids that I just showed you. They had severe social and communication delays. So it may be that the kids who get identified early and start treatment early, some of them get so much better that they no longer meet the criteria for an autism spectrum disorder by the time they're 4. And my colleagues in Connecticut are following these children more intensively and trying to understand what features at age 2 might predict that kind of superb response to treatment, or what treatments might be the most effective, but that data is still being gathered. So going back to the positive predictive value for a minute, remember, it's not so good if you look at the MCHAT alone. It's better if you look at the MCHAT with the follow-up interview, but even that's not the whole story. If you look at low-risk children compared to high-risk children, the low-risk children, there's lower confidence in their screening results, especially when they're under 24 months. So the children who are screened at age 2, we can be more confident in their screen results. But I would never suggest that we just wait until 2, because the children who should be identified at 18 months need that 6 months of treatment time. So you just have to weigh the pros and cons and the risks and the costs of earlier versus later, low risk versus high risk, to come to kind of an informed interpretation of your screening results. There are lots of other factors that influence screening results. And we did a study, again, this is a subset of children that we collected from a low-income clinic where many of the families don't have health insurance. And we found that the mothers who had not gotten a college degree, their children screened positive at about double the rate of mothers who had a college degree or more of formal education. And now we don't think autism is more common in the families who are of lower socioeconomic status. So maternal education is a marker for the family's overall SES. What we think is that there are other factors influencing the way they're answering the questions. And it turns out that when we do the follow-up interview with them, the higher education group, they are much more likely to stay positive, showing true autism risk, whereas the majority of these moms, when we get more examples and more information from them, many of them drop into the low-risk category. So they're over-identifying at the first stage and then evening out at the second stage. And there's no difference in the prevalence of autism between the two groups. We're also very interested in cultural factors. So we're looking at race and ethnicity. And so this is data from a student's honors thesis. This is one of my star undergraduates. And what she did is we had an open-ended question on our history form. So when a parent screened positive and was invited to come in for an evaluation, we asked them a ton of information about their pregnancy and early childhood and developmental milestones, everything under the sun. But before we got into all those questions, we said, do you have any concerns about your child? And then we coded what they wrote, and we mapped them onto the DSM domains of social, communication, restricted and repetitive behaviors, and we also looked at some other non-ASD features like disruptive behavior or motor issues. And what we found is that there's no difference between African American in blue and Caucasian families in green in terms of the kinds of communication delays or the restricted repetitive behaviors that they report. But the African American parents were far less likely to report social concerns. So things like eye contact, pointing, interest in other children than the Caucasian parents. So what we need to do now is try to understand why there's a difference in reporting and figure out how we can best serve the families that may report things or may interpret things a little bit differently from other families. I also had a student who was interested in whether there were certain items on the MCHAT that were different. And so she looked at individual items, comparing African American and Caucasian families, and controlling for SES. And she found that there were 4 items that were endorsed more often by the African American parents. And the only one that's social is not attracting the caregiver's attention. The others are non-social things, and we don't understand why they're being endorsed more often. But again, now that we know there's a difference, we now need to start digging into why that might be. And this is really preliminary, but I thought I would put it in. And this is actually from our new revision of the MCHAT. But we've started using the census tract as another way of estimating socioeconomic status. And so when you look at families' median income level, the families who are in the areas that earn less than $40,000 a year screen positive at double the rate of the families whose income is above $60,000 a year. And so again, it evens out at the interview stage, but something about the original questions, parents are answering them differently. We're not the only ones doing MCHAT research. I had the pleasure of chairing a symposium last year at the International Meeting for Autism Research, where collaborators and colleagues from other countries were coming to present their data. And the uniformity, the consistency from one country and culture to another is actually astonishing. So Spain has done a really large-scale study, really a couple studies put together. Japan has done a couple of studies, and they realized that parents may not always understand the questions quite the way we intend them. And so they drew some little pictures to illustrate a couple of the items that I thought was brilliant. And so we've wondered if we should start testing whether those pictures change the way parents answer the questions. The next steps that we're taking, we've developed a revision of the MCHAT to try and clarify the items, rephrase it a little bit. So we took the question that was kind of British in its sound of, does your child take an interest? And changed it to, is your child interested in other children? And we've simplified it. We've given them some examples. So we don't want them to give us like 5-year-old level of showing interest in other kids, like approaching and inviting them to play and everything. Does your child watch other children? Does your child smile at other children? So we're giving them the developmentally appropriate level to answer the question. And what we're about to do is collate data from another 10,000 children who have now been screened at 18 or 24-month checkups. Some children have been screened twice, but it's kind of a battle to get the doctors to do it twice. To evaluate whether this revision reduces the false positive rate and improves the, without reducing the sensitivity, so improves the overall efficacy of the tool. And then the next step is to, again, take it to the field and see if pediatricians can implement it, use it, score it, interpret it, refer appropriately without all of the research support that we've built into our initial studies. So I wanted to make sure I left plenty of time for questions. I left at least some time for questions. So I'd like to open the floor.
Questions? Thank you, Dr. Robbins, for a wonderful talk. Questions? Okay, some over here.
I was wondering how your research might end up changing with the change in definition that might be coming with what is autism and sort of the more restrictive definition.
Yes, we're actually really worried about the proposed DSM-5 criteria. We've looked at our sample of the 18,000 children, and if we applied the criteria as they were posted last spring, actually I think it was maybe a year ago, more than 60% of the toddlers that we diagnose would not meet criteria. And I think that for some of these children, what we're doing by finding them so early is catching the emergence of the disorder. And so they may not be showing all the symptoms that older children display. And it really worries me because early detection is critical for early intervention. And if we know early intervention is critical for the best long-term outcome, we don't want to restrict the diagnosis to only those most severely affected children, because then the other kids who need that early treatment aren't going to be eligible for it.
I should mention we were talking about an article just before your talk that's on NewYorkTimes.com right now on this very subject. A paper recently published suggesting that the new criteria would essentially eliminate the autism epidemic, that the new DSM criteria would basically greatly decrease the prevalence of the disorder.
So that's already making a presumption that there's an epidemic to begin with.
Right. Other questions?
Do you think what do you think are some of the barriers preventing pediatricians from using your screening tool? You said that more and more pediatricians were using them, but you mentioned time, and do you think there's enough training, and what other obstacles do you think are important?
I think there are a lot of them. So time and money are some of the most commonly described barriers when people do focus interviews and talk to the pediatricians. Training is interesting. So the questionnaire was designed to be administered and scored by somebody without special training in autism. That's the idea of making it standardized. You take the expertise out of the administrator's hands. So I think the issue is that some pediatricians still don't feel comfortable referring such a young child for such a severe possible disorder. And if they were able to get more comfortable with the idea that let the specialist spend some time with the child and the family and get a better sense of the strengths and weaknesses to direct them towards any intervention that might be helpful, and make it less of a, oh, let's put an early label on this child, because it's not really about labels. It's about communicating the strengths and weaknesses to get the effective treatment. And so I think that barrier is not so much about education about what autism looks like, but education about how a referral can be beneficial and not be pejorative to the family.
Question? Anyone? Okay.
I feel like I should make a comment. I'm probably the only pediatrician in the audience. I'm one of the academic pediatricians from St. Christopher, so thank you for a very nice lecture. I found it very interesting. The barriers that you mentioned are exactly what are our troubles. There's no reimbursement, and there's more now, so I think people are spending just a little bit of time, because some insurance companies will reimburse for the time you spent doing an MChat. But probably the biggest problem is where to refer them after we have the problem, what kind of things to do with these children. Fortunately, we have early intervention services here in Philadelphia. I was working in the suburbs for a number of years, and it's sometimes very difficult to get the kids to go someplace. And many times you just mention to the family that there might be a concern, and when they want to know what to do with it and you have no place to send them, that becomes a very much of a barrier for us. So I don't know if you can comment on that aspect.
It's a huge public health issue. So every state has an early intervention system, but how well it works is highly variable. And within states, usually more urban areas tend to have more resources than more rural areas. And some states will do a lot without an official diagnosis. Others kind of hold back and don't give a lot of services unless there's a clear diagnosis that warrants more intensive intervention. So I think the variability is a hurdle that the whole system needs to take on, not just one place or one professional. And we were talking a little bit about how you guess at the cost, right? How how is it $3.2 million over the lifespan of a person with an autism spectrum disorder? And my guess is if you took a much smaller amount of money and invested it into that early, intensive, high-quality intervention, you would need less care over the lifespan, and you would increase quality of life and many other factors that it's hard to put a dollar sign on. But getting the system to invest more at a time when we are pretty much cutting back everything seems like a really huge systemic problem. And I don't have a good answer to that, except that the more parents clamor for it and show the need for it, I guess the more attention it gets, and maybe that will help propel things forward. The parents who are listening to the let's wait and see, maybe he'll come around, boys develop slower, those kinds of things that a lot of parents still hear from professionals won't help change the system. So although I cringe when I send families off knowing that in Georgia the statewide system does not have the resources that it needs to serve the children, I still give them lots of suggestions of things they can do at home and books that they can read, and it's probably not the same as going and seeing a specialist every day for several hours a day. But I'm hopeful that we'll continue to develop low-cost ways of at least delivering some of the interventions that are showing to be effective.
Time for one more question, if there's anyone. If not, one more question.
I have a question that it is impressive that we have seen a child, he got improvement because he can simulate your spleen juices. So I want to know what method you have employed to get such improvement. Thank you.
Right, so I'm not actually doing the intervention with these kids. So when I see them, it's for the diagnostic evaluation. And then when a child has an autism spectrum disorder, I talk to the parents about what the American Academy of Pediatrics recommends, which is 25 hours a week of intensive services, mostly one-on-one with specialists who have expertise in autism, and very few kids get that. And the truth is, we don't know if 25 is a magic number. We don't know if 15 hours is going to be enough for some kids or most kids, but the goal is to point them towards as many resources as they can. So every family checks in with the state system to see what they'll offer them, but the families who have the financial resources to seek private services usually supplement what they get from the state. Now, obviously not all of our families can do that. But what we are doing is every 6 months we are seeing these families for an experimental session where we're trying to develop some more fine-tuned measures of how their social engagement, joint attention is developing. And at each visit, we're asking them to tell us in great detail everything that they've done, every specialist, every treatment provider, and not just quantity like how many hours, but we ask them, do you think it's helping? What do you think is working? Which specialists do you feel are really listening to you or really, getting your child? And so we're hoping that this qualitative data will at least point us in the direction of where to put our energies when we start turning to the intervention research. And there's other groups out there doing intervention research already, but I have not yet done that.
Great. Thank you, Dr. Robbins, and we'll see you guys in 2 weeks for our next grand rounds. Thank you very much.
Thanks.